Hello everyone, my name is Mike Gonzalez and I welcome you to Target Blood Pressure. I was your host back in August when we had this virtual kickoff with CPCA and the American Heart Association with Target Blood Pressure, or short Target BP. Last month we talked about the urgency to bring to blood pressure control as an area to really improve cardiovascular disease and stroke. And last month we encouraged everyone to sign up for this great initiative called Target Blood Pressure. Today we have a presenter. His name is Dr. Go. But before we get to the presenter part, I want to encourage everyone who has not done it yet to sign up for Target Blood Pressure. In the end of our session, we will talk about how to sign up. But for those of you who would like to do that as we go through this presentation slide deck, feel free to visit www.targetbloodpressure.org. Again, that's www.targetbp.org. So I would love to introduce now Dr. Go, who he will be presenting on Target Blood Pressure. Dr. Alan Go completed his internal medicine training and a general internal medicine fellowship in clinical research at the University of California, San Francisco, before joining the Kaiser Permanente Northern California Division of Research in 1998. He is currently Chief of Cardiovascular and Metabolic Conditions Research, Director of the Comprehensive Clinical Research Unit, and Regional Medical Director of Clinical Trials through the Kaiser Permanente Northern California Division of Research. He is also an Associate Professor in the Department of Epidemiology, Biostatistics, and Medicine at UCSF, and Consulting Professor in the Department of Health Research and Policy at Stanford University. Dr. Go is the past chair of the American Heart Association Epidemiology and Prevention Council Statistics and Stroke Statistics Committee, and the lead to the American Heart Association, the American College of Cardiology, and the Center for Disease Control Hypertension Advisory Statement published in 2013. I would love to introduce Dr. Alan Go as he presents to you all more about this great initiative called Target Blood Pressure. Alan Go.
Good morning. It's a pleasure to be able to participate in this webinar in participation and collaboration with the California Primary Care Association and the American Heart Association to focus on high blood pressure and the Target BP program. I'm very pleased to be involved with the organizations in highlighting the importance of high blood pressure and what we can do to improve the population-based control of this condition. I'd like to start out by reminding all of us about the importance of high blood pressure, and at a population level in this country, it's an estimated 80 million adults actually have high blood pressure, representing 1 in 3 today who are living with high blood pressure. What you can see here too in this table is, as we well know, that high blood pressure or hypertension is at different kinds of levels of severity. And you see it's really based on the degree of elevation in systolic or diastolic blood pressure. There's a few important other aspects to this. In particular, we know that the prevalence of high blood pressure varies by different demographic characteristics. So in white European patients, it's roughly about 1 in 3. But it's more common in Black African Americans, approximately 2 in 5, and is important in actually almost any other ethnic group, including Hispanic Latinos, which is about 1 in 4. These are data from the American Heart Association 2015 statistical update, which I encourage people to read also, as it highlights a lot of the at-risk groups that we have to manage in our practices. Now, we know that it's a very prevalent problem, but why is controlling blood pressure so important at an individual level and also at a population level? We know that there is excess morbidity and mortality that is due to cardiovascular diseases that are directly related to elevated blood pressure. We know from many, many studies that are epidemiologic that people who have high blood pressure or hypertension are at increased risk for this. And importantly, when we lower the blood pressure, we're able to reduce the amount of damage to those organs. Most importantly, the brain, the heart, eyes, kidneys, but we're also learning that just the general impact on the blood vessels can be very significant and leads to a variety of complications. It is, though, truly a modifiable risk factor. Since the 1960s and some of the landmark veteran affairs trials, we know that treating high blood pressure, systolic blood pressure in particular, using a combination of both lifestyle and medication efforts can reduce the risk for heart attacks, ischemic stroke, hemorrhagic stroke, or intracranial hemorrhage, as well as death due to cardiovascular conditions. And this is really critical because, particularly in primary care, we are part of the front line to be able to implement this. It's also important to recognize that blood pressure is even more tightly associated with strokes than it is to heart attacks and other cardiovascular conditions, but all of them are very important, and recent data from the SPRINT trial has demonstrated as well the importance of treating high blood pressure, particularly in the elderly. So how are we doing as a country? If you actually look at some of the most recent data on blood pressure control, it's not as encouraging, I think, as many of us would like. So even though there's been an overall reduction in coronary heart disease overall, we know that for high blood pressure, we have a lot of room to improve. As you can see here in the upper left circle, about 46% of people with high blood pressure, or nearly 37 million Americans, are actually not controlled currently. And the American Heart Association has made it a goal that in this country we move nearly 14 million people to control by the year 2020. Now the good news is even though that's a lot of people, we now have demonstrated that at a population level we are actually able to do this if we're able to implement systematic approaches to controlling blood pressure. Several large healthcare organizations and health systems have been able to implement successfully ways that treat both the individual and the population. We have to address a number of different problems. So as you see here in the lower part, only 54% of known U.S. adults with high blood pressure have their high blood pressure under the target control, which is currently less than 140/90. This is reflective of the fact that only 77% of patients with high blood pressure are actually getting treatment with some pharmacologic agent. And as important, 83% are aware of having high blood pressure, which is good, but really needs to be close to 100%. And you see in the very far right lower circle that about 20% still remain undiagnosed, even though they may have one or more blood pressure readings demonstrating that it's high. So the approach to ultimately meeting our goal by 2020 of controlling, and again, an extra 14 million people in the United States, really requires that we tackle this in a systematic way and provide the kinds of tools needed in primary care and other subspecialties to be able to achieve this goal. So this brings us to some more within the last couple of years. The American Heart Association has partnered with the American College of Cardiology and the Centers for Disease Control back in 2013 to come together in recognition of this problem and put out a scientific statement which highlights the best practices and the principles in clinical care that can improve high blood pressure control rates. And just as important, to put forward a template to say, here's one way you can customize an approach based on successful principles and practices to be able to get your patients and your practice to a higher level of quality for blood pressure management. And so for the rest of this talk, I'm going to share really the premise behind doing this and a lot of the practical steps to be able to help get our practices and our patient populations under control. This has been a terrific partnership with the American Heart Association to highlight the importance of this problem and to help move us, again, as a country closer to achieving these goals. And that brings us to the Target BP program. And I'd like to just summarize the sort of three main goals around the Target BP program and then walk through some of the individual components. I think fundamentally, the Target BP program is really a call to action. Again, now that we know we have tools that can be effective to help control BP on a population level, this is a call to help motivate all of us, individual practitioners, medical practices, and healthcare delivery organizations to make it a priority to control blood pressure in our adult populations. If that was it, it wouldn't be enough. And so one of the other aspects is to really recognize the healthcare providers and practices who are doing a good job. And it's important to patients and to their families to be able to receive treatment from providers who are able to do this, particularly those who get on the order of 70 or 80% or higher levels of control across their populations because they've been able to both systematize and personalize that type of care. And thirdly, we want to support new practices coming on board as well as existing practices to utilize tools and different assets that can help them get there. If you're not there yet, we want it to be help you get there, and we've provided a lot of information through our hypertension treatment scientific statement and algorithm, as well as the AMA's MAP checklist. So these are just three main overall comments about the Target BP program, which is a terrific program for you to consider signing up for in your practice. Now, who is the target audience for this program. It's really focused in primary care, and that makes a lot of sense. Again, primary care providers are the front line. This is really part of the bread and butter of what we practice every day. And I've shown here really all of the different systems that are involved, as many of you know, from federally qualified health clinics and the rural health clinics, the Indian Health Service, as well as practices that are focused on high-risk populations in the underinsured and uninsured populations, but of course also in private clinical systems, and frankly, all of the integrated and large healthcare systems in the country. That includes government agencies and organizations as well. So really the goal is to help empower our primary care providers, whether you work in a small clinic or in a large health care system, to be effective in moving toward higher quality blood pressure control. And just to really hopefully really assure people here is that large healthcare systems taking care of millions of people have been able to implement much of what I'm going to talk about in a way that can get close to 90 to 95% control in known hypertensive patients. And so really want to empower people to know this can be done, but it will take work and it's going to take a systematic approach. So what is that approach? It's really taking a step back and understanding that it is going to require multiple levels of stakeholders here, which we like to call the strategic multimodal approach. So number one, it's really important that we equip our providers. We know that our primary care providers in particular are really trying to do the right thing within very busy practices and with the vagaries of the current healthcare systems. One of the ways we've seen this to work is to be able to provide more standardized protocols that can help get the majority of patients where they need to be using a standard approach without losing the personalization. We also want to be able to provide incentives that help both individuals and practices to reach those target goals, and as I mentioned in an earlier slide, to be able to recognize those providers and practices that are doing a great job. We've also learned that team care is particularly important for managing a cardiovascular risk factor like hypertension, and being able to both empower those to work within their skill set and within their scope of practice to be an effective part of a therapeutic team for, again, practice level and population level control. We also know that a second really important aspect is to motivate and connect our consumers, our patients, to be able to be a part of that therapeutic team. We know, too, the advent of so much great technology is beginning to facilitate the ability to have patients be a big driver of getting to goal. So how does that happen? Well, number one is we're very supportive of trying to get validated blood pressure devices to be made available throughout this country for our population. And that will be a really critical piece, because if you can't measure it, you can't improve it. We also know that partnering with employers, where many of our adults are at work throughout the day, both to monitor but also to be a positive site to stimulate lifestyle changes. We also want to leverage technologies that can connect our patients, our consumers, with their healthcare providers, and also provide both personal and practice incentives along with the patient to be able to achieve those goals. Many people know the phrase, it takes a village, and we think it does with regard to improving population control of high blood pressure. Communities can play a very valuable role in helping to get cardiovascular risk reduction done at a massive scale. We know that can look like many different kinds of solutions, and so we just highlight a few of the different examples of how some communities are really tackling this. This can go from health ambassadors that serve really an educational role to be able to help access particularly patients that are hard to reach. We also know that working with pharmacies where patients pick up their medication and are able to get information and education and understanding the role of medications for blood pressure control. Being able to get applications out through smartphones and through the computer that allows patients to interact with their healthcare provider to track how they're doing over time, and to have their providers know how they're doing is another aspect. And even increasingly, many communities are activating healthcare workers who can go out and be even more effective as part of a global team to help with things like medication adherence, testing, and monitoring. And again, on a scale, what's really important is that systems of care in this country, particularly those that have been facilitated through the Affordable Care Act, are facilitating the ability to have accountability at all levels. And this means development of evidence-based performance measures that make sense, that are based on the best level of evidence possible from randomized trials and also from quality improvement efforts. We also need a systemic and systematic surveillance system that I'll talk about a little bit, leveraging our electronic medical records. And also, we need to be able to provide feedback on a regular basis and have a continuous quality improvement culture that helps us to really move more quickly to get to our goals with regard to high blood pressure control. So as you can see here, this is a type of framework which is not just at the individual patient level, but stepping back to look at our practice and where our patients and their families sit within a community, and at a healthcare system level, what role we play and how we can incentivize overall systems of care to help individual patients and providers to get there. Now, that's a great transition to begin to think about what are the kinds of system-level methods that we've implemented in many places to improve high blood pressure control. So I'll walk you through really a number of things that we believe are extremely effective and would encourage people to consider solutions for doing that. Number one, it starts with identifying all of the eligible patients who have elevated blood pressure. The good news is that with the near universal implementation of the electronic medical record and the fact that at almost every ambulatory care visit people have their vital signs measured, we should be able to identify everyone with elevated blood pressure or have known hypertension on treatment. This means being able to track them systematically over time, and that we monitor at the practice and population level so that we know how we're doing, and as new patients enter the practice, we can decrease the time it takes to make them aware of the high blood pressure and the patient level, and also to be sure our providers know so we don't have long delays in both the evaluation and treatment. To do that right, though, we need to have treatment guidelines and diagnosis guidelines that are evidence-based, readily accessible at the time of care, as well as having a way to review on a regular basis our practice population. This means having a systematic follow-up plan, again, for existing patients and the identification of new patients so that we have patients that don't get lost in the cracks. This means that it would be helpful to have a systematic team approach. We leverage our extremely skilled healthcare members to delineate what roles they can play to help the physician and other providers in the whole system to be able to get toward goal. We also know that it's not easy, as we talk about things like lifelong therapy for patients, to be able to achieve high levels of medication adherence. So one, we need to identify what those barriers are, from just accessing the medications through being able to take the medications and addressing any side effects. And also, a really important aspect is that just because you're on medication does not mean that there isn't a key role for doing lifestyle modification. And those aren't always easy to address, but being able to lower the hurdles for how we can help patients individually adopt lifestyle modifications that can be helpful in conjunction often with medications is a key aspect. And as I mentioned, a real backbone to all this work, we believe, is to leverage the expanding electronic medical record system that, again, is nearly ubiquitous throughout the United States. And we believe that all of the major makers of the EMRs are putting systems in place that can begin to help support each of the steps I've outlined above. So what are really the principles and goals for us to be able to ultimately get high blood pressure under control? We believe that whether you use the American Heart Association, ACC, CDC guideline, or another evidence-based guideline, it really comes down to a series of principles and goals that are extremely similar. It's just on how you implement it. And first and foremost, all of the effective algorithms that are being used really rely on having the best available science in terms of what therapies work. So randomized clinical trials, particularly large ones, have been extremely helpful to identify which therapies are effective for lowering blood pressure and also translating that into cardiovascular and other benefit. We also know from rigorous observational studies what types of solutions work and can they be scaled to do population-level control. So it's really a combination of the randomized trial as well as observational studies that can help us determine what we do and also begin to learn how best we can do it. Of course, science never stands still, so we need to be able to format any kind of algorithm in a way where we can update it regularly. As new clinical trial data, as new observational study data become available, we want to be able to put this in the hands of providers and healthcare team members and patients so that they're really well informed and we can modify treatments. That means that we want to have feasible and relatively straightforward, simple implementation strategies that include, again, the identification, the diagnosis, the treatment, and the monitoring. Try to keep it straightforward, incorporate it into our individual workflows, and have a way of systematically tracking. And because the patient is really a critical aspect of this, they really are a partner, we need to make sure that we have tools and information for them that they can understand. Because we know that when patients understand their condition, why we're asking them to do things, they're much, much more likely to adhere to that. And so we have to make sure that things are written and prepared at a literacy level that is appropriate to our different patients, and also ones that are updated to reflect our current practice. Increasingly, we have to pay attention to cost in our healthcare system. And that means thinking through strategies based on your populations and your practices that can be able to be effective within certain cost constraints. The good news is, at least with regard to medications, is that we now have many low-cost medications that have been proven to be effective. We also know that many of the lifestyle modification strategies have low cost and can be adopted and incorporated as part of people's general lifestyle, and that's really important to know, for them to know that. It really is a lifestyle change that we're asking them to adopt. Again, teamwork is critical for blood pressure control, particularly on the population scale. And so any algorithm that's used needs to really delineate clearly which team members can do what, and we want to make those workflows easy and work within the flow of a practice or within a healthcare system. We believe that electronic health records will facilitate that, and really that we can develop clinical decision support tools embedded into the electronic medical record that can be very widely scaled to help practices who adopt these electronic medical record systems to be able to incorporate that, again, on a daily practice level, as well as on systematic reviews of their patient population. We believe that there's pretty clear evidence of who benefits from certain therapies, and where there is that kind of consensus, the electronic medical record can be used then to help us to do the right thing for the right person at the right time. And that's where we believe that this is changing in a positive way. Now, one of the questions that almost always comes up is, well, does that algorithm apply to everyone and to every patient in my practice? And I'd say that we want to make sure that there's an algorithm that can apply standard approaches that will help basically take care of the vast majority of patients and to get them safely to a high blood pressure goal. But we want to make sure that it's done within the best clinical judgment of the treating provider. We know that not every patient will respond within an algorithm and a protocol, but we know that the majority will. But we want to make sure the treating provider understands that they use their clinical judgment, and that there's going to be a certain proportion of patients that will need to get additional type of evaluation and care, and the algorithm really that you use should be built to that is actually the case. So this gets there to some other key principles of these kinds of algorithms that we know can be effective. One, that it's clear, and again, that it's simple. It's easy to understand. We also want to make sure that even with medications, that we highlight the value of lifestyle modification choices, and I'll briefly describe really the domains of those lifestyle changes. We know, too, that it's very important to treat by level of blood pressure, and we'll talk about, as just a brief example, how the AHA-ACC-CDC treatment algorithm really starts right there at the level of blood pressure. How high is it? And that's going to tailor both our follow-up plan and our treatment plan. Regardless of how elevated, though, it is very important that there be titration of medications and systematic reassessment of any patient with high blood pressure. Many years ago, people would be treated with a medication, for example, and wouldn't be seen for potentially a year or more, thinking that it's a fixed dose type of approach. We now know it's really important to keep the patient engaged and also ensure that we're titrating to an appropriate blood pressure level and assessing for both compliance of medication, lifestyle modification, and any side effects, so that we can help people stay under the treatment goal for as long as possible for the rest of their life. As I mentioned before, a critical aspect is also to be really aware of the costs of medications in particular, and to be able to have access for patients and to use low-cost first-line therapies whenever possible. We know this is very important as healthcare financing is changing and will continue to change, and we want to reduce the burden on individual patients and their families. We also know that we have to be aware of what patients are not actually eligible for certain kind of medications, either based on concurrent medical problems, contraindications, and that does require a systematic assessment of the patient, and also an algorithm that provides alternatives for those kinds of patients, again, using the best clinical judgment of the provider and on the best available evidence. So with these kinds of principles, we want to also think about the idea, well, what if a patient doesn't respond? And we do know that there's probably a relatively modest proportion of our patients who will actually not respond to our initial treatment algorithm. And there we want to have a heightened sense of awareness that there may be secondary causes of hypertension or resistant hypertension that needs to be further evaluated, and that's important too to understand. But again, the vast majority of patients will do well with a standardized treatment algorithm. In addition to just following that kind of algorithm, there are other kinds of approaches that have been developed that can improve adherence, and this includes fixed-dose drugs that can work for certain patients, as well as single-pill combination of multiple drugs that also can be highly effective. We also know from recent trials that for patients with hypertension, the vast majority will end up taking 2 or 3 drugs, or even more at times, during their lifetime to ultimately stay under control. And this is important even when they're doing the best they can with lifestyle modification, that they don't see this really as a failure, but really just part of the natural history of what can happen to patients with hypertension, and that this is not something that they're not doing right. But it is just like many other conditions, and so it's important to have patients understand that. As well as if things aren't going well, when it's time to refer to a specialist in hypertension who may be able to address the underlying secondary causes or to do more detailed evaluation in the small proportion of patients who don't respond. We also know that medications in particular can lead to side effects that can impair quality of life and functional status of patients, and it'd be important to understand that and be able to give patients accurate information about what their really individual risks are for both the benefits but also some of the side effects that may occur with the different treatments. And importantly, we as practitioners and healthcare systems, we really want to make sure that we are relying on good evidence and also that it's current. So any algorithm should also have an ability to quickly reference that material. That way, if people want to look into what is driving a particular recommendation, they can quickly get to the source information and evaluate it for themselves, as well as look at key reviews and meta-analyses and other kinds of systematic reviews that can be very helpful in summarizing all of the existing evidence together. So with that as a background, I just want to show you an example of an effective treatment algorithm. This is the American Heart Association's. I just want to highlight a couple things real quickly. On the right side, you see a table of the different lifestyle modification approaches, and it's linked to specific recommendations, and based on both clinical trials and observational studies, what might be the expected reduction in systolic blood pressure. Now we know this is going to vary by individual, but it's really to highlight the fact that lifestyle modification can in fact be very effective for individual patients in terms of being able to reduce blood pressure, and it will work actually even more so when it's combined with medication, but that the actual amount of reduction will vary by patient. So briefly, that we want to focus on maintaining a healthy weight, and that there are recommended types of diets that are effective in helping to reduce blood pressure, often linked with lowering the amount of salt in the day as well, even though we know there's continuing discussion and review of the evidence and new evidence for that. Independent of diet, physical activity, particularly by increasing regular activity that has an aerobic component, can be effective. And having moderation of the alcohol consumption, as you see here, does refer particularly to gender-based recommendations, but collectively you can see that each of these individually and combined can help in helping to control blood pressure. Now on the left side, as I mentioned before, any algorithm that's effective will start out by first understanding how severe the blood pressure is, and based on that, make recommendations in terms of what might do. Less severe blood pressure, there might be a very brief lifestyle modification effort, but almost always people will end up moving toward a therapy if it's more severe, you'll see the recommendation is often both a combination of therapy and lifestyle modification right off the bat, and often dual treatments together. Either way, there has to be a systematic recheck that is based on severity, and you can see here in the lower boxes. And from there, I won't walk through all the details. This is really just an example, but it's meant to show that you have a branching algorithm that hopefully has no ambiguity in terms of what you might do and has systematic follow-up, even when they're at goal. I want to point that out, that even when it's yes at goal in any of these arms, that you want to make sure that there is continued follow-up and routine monitoring. And there's also, as we mentioned before, an important aspect that if a person isn't doing well, they can get out to a hypertension specialist. So in the source document for this, you can read through all the details of how one might approach this. Just wanted to highlight for this group that this is one form of effective algorithm. There are many out there, both from different successful healthcare organizations, such as the VA system, Kaiser Permanente, as well as other healthcare systems have also very effective treatment algorithms and population-based strategies. So with that, I wanted to conclude by encouraging practices to really strongly consider registering for the Target BP program. On this slide here, you see 2 different contacts that you can go to if you have more questions, or to the website to get more details about how this program might be helpful to you and your patients. And we believe that these types of programs will be extremely effective in helping us move toward our national goal of getting close to 14 million new adults back under control, and ultimately to meet our goals of reducing the cardiovascular burden in this country. I really appreciate the opportunity to speak with you, and continue good luck to everyone as they continue to take on this big challenge in this country. Thank you very much.
I'd like to again thank Dr. Alan Go for his time today. He did a great job in outlining the urgency to bringing to controlling blood pressure through the American Heart Association algorithm. I'd like to again encourage everybody who has not done it yet to sign up for Target Blood Pressure at www.targetbp.org. You're more than welcome to email me any questions. Again, I am Mike Gonzalez. To clarify on this last slide, the email indicated is incorrect. It's Mike, M-I-K-E .Gonzalez, G-O-N-Z-A-L-E-Z @heart.org. Again, for any questions, concerns, feel free to email me directly. For those of you who will be signing up today, I'd love to just clarify some points as you sign up. When you go on the website, please make sure to have some information with you as you sign up. It's a quick 5-minute sign up, but there are some information you need in advance. The first is knowing your adult population size for your healthcare system. Second, knowing the percentage of your total patient population that has been diagnosed with high blood pressure. Again, within our guidelines, 140/90 is considered high blood pressure. Also, for those who have been diagnosed with high blood pressure, knowing the percentage that are under control. Again, knowing these numbers are the first for us to work together to improve the numbers around blood pressure and controlling our adult population. Again, it's a quick 5-minute sign up, but again, it's great to have this info in front of you if you have it. If not, please find this information out. Again, targetbloodpressure.org, quick 5-minute sign up. For any questions in the future, feel free to email me directly, again at mike.gonzalez with a Z @heart.org. I thank you all for your time today, and I look forward to the next webcast. Thank you.
In closing, CPCA is very excited about the partnership with the American Heart Association's Target BP initiative. And so we just want to show you just how simple it is to enroll. Simply visit the targetbp.org website. You'll click on the Register Today button there in red on your screen. Simply fill out this profile information and answer a few simple questions, and be sure to agree to their terms and services by clicking this last checkbox before you hit Submit. You will then immediately receive an email communication with lots of tools and resources to help you get started with this exciting new program. We thank you so much for your time, and have a great day.